Good day to everyone. All right, so today you are here for this seminar on USMLE and US Residency Pathway. All right, so together with me is Dr. Charles Vasilis. He is the Chief of Staff at Washington, D.C. Veteran Hospital, internal medicine specialist, and he's also the Director of Clinical Skills at the Becker's Education Foundation, all right? A little bit of background of Dr. Vasilis. He has received several teaching awards, namely Attending of the Year, the Osler Award for Teaching, and the Golden Apple, right? So currently he holds the position of President for the local chapter of American Society of Hypertension, and he's a member of American College of Physicians, and he's also a member of Alpha Omega Alpha Honor Society. As for his educational background, Dr. Vasilis received his medical degree from the University of Athens School of Medicine, and he completed his residency in internal medicine at Cook County Hospital and medicine fellowship at the University of North Carolina. At present, he is a faculty of George Washington University School of Medicine, and his research interests includes hypertension, diabetes, patient safety, and also medical education. So let us now welcome Dr. Vasilis to deliver his talk.
Thank you so much. I think I'm gonna. I can't walk around now, right? I have to stay here. Well, they won't hear me though, right? There's no. Oh, I could take it off. Oh, okay. I just want to make sure. Oh, perfect. All right, that's better for me. All right. Good afternoon, everybody. And my name is Charles Vasilis, and thank you for the introduction. One of the reasons I got involved in medical education and students' education is because many years ago, about 20 plus years ago, I was in your seat. I was an international medical graduate at the time in Europe, and I decided to take the examinations and go to the United States. It was very, I thought it was good training for me, and I think I will take you through this journey to understand what it takes to go and train in the United States, and it's a commitment. It's not an easy thing. You have to really plan your schedule, and you have to plan your career going into the future. So here's a couple of the facts and the important issues. So for some reason, okay, let me try this. That's okay. There we go. Okay, this works now? Okay, very good. So one of the important things is understanding that getting a residency in the United States means you have to pass certain examinations that they view essential for people to do residency in the United States. These are called the USMLEs. And there's actually 3 components. There's actually 4 tests. And the first one is the USMLE Step 1, which I'll explain a little bit, but it has to do with the basic sciences, I think what most of you are doing now. The second component is Step 2, which is Step 2, the knowledge. So they say, they test how much you know about the clinical sciences. So that's for you, that's the latter years in medical school, year 3 and 4 and 5. And also, in Step 2, they have this thing called the clinical skills, which you go up and you do 10 to 12 cases with an actor, a patient actor who describes a disease, and you're supposed to know what the disease is. They're pretty simple diseases, and you're supposed to ask the right questions and interact with the patient who's an actor, and they grade you on that, and you have to pass that. That's a pass or fail. But the other ones, Step 1 and Step 2, you get a score, and that score is very important. It's very important that you try to score as high as possible. The reason is because that's the only way that you could differentiate yourself from some other candidates. And it's the only way that sometimes your application will get in front of a residency director. I had been a residency director, and in Washington, D.C., because it's a city where a lot of people want to come and train, we had a lot of applications. So, for example, at some point, 15,000 applicants for 35 positions. And not everybody's going to come to D.C. They want to go to other places, so they're interviewing in many other places. But my point is, unless you have a high score, I won't get to see your application because I have to put some filters in that, in that 15,000 applicants. I can't see everybody's application. So one of the filters I'll put is to have a high score, like at least a 230 or above on the USMLE on both. USMLEs. Some other program directors will put it even higher at 240 and above. 240 and above is about an 85%. So people that do really well, they score more than 240. They score sometimes in the 250s. And that's over the 90th percentile. You have to try to do as best as you can in these tests to differentiate yourself from the other people. So that's number one. And so let me tell you a little bit about these tests, what they're based on. So here's the objectives of step 1 and 2. So many years ago, well, not that many years ago, but about 10 to 12 years ago, the USMLE said, what's important to us? What's important to us? Having doctors that know all these rare syndromes and these rare diseases, or is it important for us to have doctors that know the common diseases very well and know how to interact with patients? Maybe that's a better doctor than somebody who knows all these rare syndromes but doesn't know, the basics of how to manage patients with diabetes. Diabetes, they say now 400 million people in the world with diabetes, right? So that's important. And then they also wanted to test how people interact with patients. That's why they put the clinical skills parts of step 2. So they said maybe these guys are brilliant in terms of knowledge, but they also have to be able to convey their knowledge to the patient and interact well with the patient, because if you don't interact well with the patient, then you can't deliver care to the patient. They don't follow your instructions. So all these changes were made about 10 to 12 years ago, but what it really comes down to is that now the objectives of step 1 and 2 is that they test the knowledge of common diseases. So in every test in the USMLE, in step 1 and step 2, and I'll tell you a little bit about step 3, that's when you're in residency, they test common diseases like diabetes. There's no test that diabetes and diabetic ketoacidosis, for example, will not be part of that test. So very important. So they tested in step 1. In step 1, they test the basic stuff about diabetes. In step 2, they test that you can diagnose and give certain medications. And then step 3, which is totally clinical and very, all management of the patient oriented, they test difficult scenarios. Like, for example, what type of insulin do you give in a very sick patient in the intensive care unit with diabetic ketoacidosis? So the same disease, but it goes up, in difficulty, in clinical difficulty, as you go from step 1 to step 2 to step 3. But my point is, these are common diseases. I can't emphasize that enough. And when they put difficult cases, and students come and they tell me, well, they put this difficult case and we didn't know what it was, and it was probably some weird disease, I guarantee you it wasn't. 99% it was some type of common disease presenting in an uncommon way. And that's okay for them to do. They expect you to know everything about the common diseases. So the focus of this exam is common diseases, and look at this, the step ones, they say that, look, they want you to know the foundations to understand what? The clinical domain. All right? So not that you understand some esoteric stuff on some enzyme and some protein, but that you understand maybe some important stuff on some enzyme or protein that is clinically significant. See, the fourth bullet point here is the most important thing, right? The link, the relationship between step 1 and step 2. So if your professors are doing what they should be doing, according to USMLE, I'm not saying they're right, I'm saying this is how they think. They should be testing you on and making you understand concepts in the basic sciences that will eventually help you understand the clinical domain. So if there's a question on your test here that stresses some issue, that's a good question only if it links to the clinical domain. If it's some, area where somebody says, well, who cares? I don't even know what this is. This is, some research area, and I'm not sure it's relevant. It may be relevant 10, 20 years later, but right now, it's unclear if it's relevant. That's not a good clinical question for this test. This test will test issues that are important clinically. Clinically, because then, when you get into the clinical arena, you're going to have to take step 2. This is at the end of your 5th year. Here, you guys do 5 years. The step 2 assesses the ability of the student to make diagnosis. Right? So look at this. Step 1, they saw that you understand what diabetes is about. That it's a carbohydrate problem. Type 1, you don't have insulin. Type 2, you have insulin, but there's insulin resistance. And some of these patients in type 1 diabetes can present with this thing called diabetic ketoacidosis. In step 2, they expect you to make that diagnosis and do something about it. In step 3, which is total management of clinical cases, they're going to give you different difficult scenarios of diabetic ketoacidosis where you have to know and change medication and treat appropriately. Right? So kind of the same diseases, but a step-up approach in terms of difficulty and in terms of the clinical cases. Right? So everybody okay with that? Any questions about that? Right? So that's the focus. And it's important because that doesn't put so much pressure on you, but it puts pressure on the medical school and the professors that whatever they talk about and whatever they focus on, it can't be like my professor, who was a brilliant man, but did research on chloride channels in nephrology, and our whole test was on chloride channels in nephrology. Nobody cares about that stuff because they're not clinically relevant. And so that's the important thing. So this is a burden on the curriculum, the professors to, and the basic sciences to connect these two, right? The clinical sciences have to talk to the basic sciences and vice versa, and we can't do anything without the basic sciences, but we can't do anything without the clinical sciences, because at the end of all this, most of you will become clinicians, right? So they have to be talking what's important, and what's important clinically, right, is what you should be tested on, right? So that's the issue. That's the whole essence of these tests. So here's a couple of things. People ask me what you need to study. people learn in different ways. So if you learn a certain way and you've proven that you learn that way, you have to follow how you learn. But if I had to generalize, the way we need to study is we have to know the theory well. And I know from your curriculum and the way that you get tested through oral exams and essays, that was the same system I grew up in and I did medical school. That's important because people doing oral exams and writing essays as tests really have to know the knowledge pretty well. But listen, here's the problem. These tests are not these type of tests. They're not oral examinations. They're not essays. They're multiple choices. And when I saw multiple choice first time as a student after I almost finished medical school, I couldn't understand what these people were talking about and how these questions were formatted. So beyond the theory, beyond really learning, what the subject that you're reading at the time, whatever that is, it could be the respiratory system or whatever system or whatever subject, you have to learn the theory first. But if you're going to take the USMLEs, look, you have to do these multiple choice questions. You have to, because you have to get facile on these types of testing. It's a certain type of testing that some of us are not used to. And now I know from your professors, they are writing questions, they are writing multiple choice questions, so that's good. But you have to do as much of these questions as possible. You have to get quick at reading these questions, coming up with an answer. On the test, you have about a minute to a minute and a half to finish this question and answer it, and go on to the next question. These exams are whole day exams. They go on for 8 to 9 hours, right? So you're going to see a lot of these questions. The Americans think by having a lot of these multiple choice questions and having a lot of them, it's an objective way to assess what the student knows. I assure you there's limitations to the system, but there is no better system right now. You will have to do that. So you will have to find some book or some type of Q bank or question bank or something that has questions like this and do a lot of them. But you don't do the questions before the theory. That's my point. You don't do the questions to learn the theory. You learn the theory, you do the questions, and you see if you're getting them right. And if you're doing fast enough, and if you see that you're not doing them that well, okay, then you need to go back and read some theory because you don't understand the subject. You think you understand it, but you don't. And here's another thing. Questions that are written well also have explanations with them. They have adequate explanations, and you could go and learn from that explanation and then enhance the theory that you already know. But if you're, for example, looking at the respiratory system and you're answering most of these questions wrong, you probably have to say, listen, let me stop with these questions. Let me go back, read a little bit more theory, understand this, and then go back to answer the questions, right? You don't want to use the questions as the theory. You have to read the theory. You have to know the theory. Yesterday, a lot of the senior students who are ready to already go to America, they're ready to leave and to get a residency there, were asking me what is a good score. So I already told you it's as high as possible. So you probably should try to get in both USMLEs 230 or above. If you get 240 or above, that's even better. If you could get above that, that is great. If you could get 250 or 260, that's amazing. The higher, the better. Right? So when you take these exams, you have to study and do these exams as seriously as possible. You don't want to be taking these exams just to see what you could do. You want to study for them and pass them as quickly as possible and get a higher score. If you don't get a higher score, if you don't get a high score, okay, you're not done. Okay, there's the good thing about the United States, there's a lot of avenues and there's a lot of hospitals that want trainees. So just to give you an idea, the mean score in step 1 for American students is about 225, 227. Right? So see, I told you guys, we demand from foreign graduates a higher score. All right? Because, you're going to be going up against other international graduates. The American graduates already are looked at differently. They're from their own country. They know where they trained. They got letters of recommendation from people in the United States. So they don't demand as much of them on these tests as you. Because for you, this is the only way that you can say, I am better than somebody else. I'm not saying it's true, but that is the only way. So you have to try to score as high as possible. More importantly, for the people that are going to go into clinical medicine, I hate to say this, but step 2 is more important than step 1. So if you're going to focus on one of the two, it's going to have to be step 2. Because if you are in an interview, I had somebody tell me one time, and I said, well, why didn't you do well in step 1? I said, you did very well in step 2. And, he said, because I wasn't really interested in step 1. I was always going to be a clinician. That's where I focused. I want to be a cardiologist, right? I focused on clinical medicine, and that kind of made sense to me. So you could talk through that, right? What you can't talk through is like, look, I barely passed step 2. You're going to be a clinician, so that's the one that you want to focus on. Okay, that as high as possible, but especially in step 2. Okay, all right, what else is important here? When you think about when you guys go into the clinical rotations, that's going to be in a couple of years. Another important part of if you want to eventually do training in the United States, which is, as I said, it's a big commitment. When you do the clinical rotations, try to complete, if possible, a rotation in the United States. So your medical school, your dean, is working with various hospitals as we speak in the United States. So for the people that want to do this, can go and do a rotation there. A rotation is maybe 4 weeks or 8 weeks. So people that are interested in surgery may want to go to a hospital and rotate there as a student and be part of the teams that rotate there. So there's going to be other students like you. There's going to be residents. There's going to be first years. They call them interns. There's going to be attendings. So the structure of the team there is very, it's very systematic. There's a certain system in place, and you would be part of that system. So what's the advantage of that? Well, there's various advantages. Other than you having to go to the United States for 4 to 8 weeks, which is a long trip, and again, it's a big commitment, there's various important implications. So one is that you could see the system because you may decide this is not something I want to do. So a lot of people come to the United States, and the people in the United States think everybody loves the United States, but some people come and they say, I never want to do this again in my life. So that's important for you. The second thing is, if you do decide to come to the United States, you say, okay, I know the system now a little bit. I know how the hierarchy functions. You are the students, you take care of patients. See, students there take care of patients. You will be delivering care to this patient with oversight from the intern, which is the first-year resident, and for more oversight from the second and third-year resident, and even higher oversight from the attending. So you have a lot. You're taking care of the patient, but there's a lot of people looking in on you. So it's not like they're going to let you do whatever you want, right? But they know how you work. So now you know the system, right? You know them, they know you, and if you do well, which I'm sure all of you will if you decide to do this, you will get a letter of recommendation from these people, the resident, the senior resident, the attending physician. That's important because when you apply to an American residency, one of one of the important things that they ask for, this is additional filters in the system. I put a filter in that says somebody, for me to look at their application, they have to have done a rotation. They have to have experience in the United States, right? So you have to check off experience in the United States, and that they have letters of recommendation from somebody in the United States. And not because I don't trust anybody here. I don't trust people in your medical schools. But when I get a letter of recommendation from somebody in the United States, I could read and understand what they're telling me. See, because they're going to write specifically how you took care of patients, how you did in terms of writing notes. I will understand really quick just by reading that letter. And if it's a good letter, and these people know how to write it, at the end, they will write, student so-and-so has waived their right to see this letter of recommendation. So this is important because not every student waives the right. By the way, they say, I want to see it. But if you want a strong letter of recommendation, you want the attending to feel comfortable to write whatever they feel they need to write about you. So when I see that and I see a good letter of recommendation, I say, yep, this person is really good. I'm pretty confident of that. So this clinical experience in the United States, it's a very important thing. I don't think it has to be done 100%, just like you don't have to get a high score in the USMLE, but I think that with a high score in the USMLE are probably the two most important parts of getting a residency in the United States. It makes you go to a different level as compared to somebody that hasn't been in the United States. So just to give you an example, I did not have a rotation in the United States. Despite that, I got a good residency, but when I started residency, people said to me, okay, get a consultant's report, do this, do that. I didn't know what they were talking about. So the only good thing, I was lucky enough to start 2 weeks early. So in 2 weeks, I picked up a lot of things really quick. My point is, you start residency there, they want you to know the system, because otherwise they have to stop, slow down, and teach you the system. Well, nobody has time to do that when you have a team that's really taking care of sick patients, a large number of patients. So remember what I said, students and residents and interns in the United States really take care of patients. They are the primary source of care in the hospital setting. That's not exactly how it happens in other parts of the world. In Europe, for example, first and second year residents have minimal, interaction with the patient. They walk in, they say hi, and it's the senior, residents that do that. That's not the case. From day one, you're going to have to jump into the fire there and take care of patients. And again, I'm not saying it's right. I'm telling you how it is. So in a way, this is an important part of that, because now they know that you know about that and that you have been tested in an environment like that. Okay, so a little bit more, just a few words about the clinical skills. Clinical skills is pass or fail, right? And so we pass the knowledge, we pass step 1, and we have to pass step 2, the clinical skills, right? So we did step 1, we did well, right? We did step 2, the clinical knowledge of step 2. which is like step one, questions, and now they have to show that we can interact. We could use this clinical knowledge that we have and interact with the patients. We have to be able to apply it to the patient. This test grades your interaction with the patient, right? Most of the people in the United States, they pass this. So in our school, the passing rate is 97%. In most medical schools in the United States, it's over 90%. So it's not a test that most people fail, but look at this. Look at this. Look at the international graduates. So 1 out of 4 people fail this test. It's pass or fail, no score. So why do you guys think, why do you think the international students fail this more significantly than the American students? So listen, it's not because they know less, right? Because I told you, when it comes to tests, step 1 and step 2 CK, it's actually the foreign graduates like you all and myself do much better. We know much better theory. We know much better, you know, how to be able to understand these diseases. They know it, but they're a little bit more superficial because they do it in 4 years. So we do better. But so why is this difference? Look at that. 20% difference in some cases. So a couple of reasons, right? One is there's sometimes a language barrier, right? So some language barrier is important. So, you know, I said that to somebody yesterday, and she said to me, wait a second, well, you know, we don't know. English is not first language to us. And they should understand that. They do understand that, but they don't care. Because they say, if you're taking care of a patient, you should be able to do what? You should be able to speak to them. They should be able to understand you, right? They should be able to, right, convey information to the patient about serious disease, right, about medication treatment, and you should be able to connect with the patient. Otherwise, you know, they don't take the medication. They don't follow up because they don't understand what you said to them. And I don't mean to be harsh. English is not a first language to me. But speaking well and understanding all this and what the patient says, and sometimes, you know, Americans use a lot of jargon, right? So you have to be able to understand that. And they will test that on this clinical skills. Now, you are all very lucky because you learn medical school in English, and most people here are excellent speakers. But listen, Europe, that's not the way it goes. I mean, people in the Greek university, they learn in Greek. You know, in Romania, same thing. In Russia, the same thing. So there's variability in international graduates in terms of how much they know English and how well they speak the English language. So that's one thing, knowing English, understanding English, speaking English well. That's one of the reasons why there's such a difference. And the second issue is this. A lot of schools don't focus on the clinical skills. So where I am a faculty member at George Washington University, we have built a simulation center. They spent over $10 million to build a simulation center where students go and they get actors, and they pay them and they give them all these clinical scenarios. The actors love it. You know, now they could be themselves. Right, so you give them a scenario with an anxious patient, and this guy loves it, and he conveys this to you, and all that stuff. So they have all these actors, where they bring them and they interact with the student, and they go through different clinical scenarios, and you guys are lucky in that way too, because I saw yesterday you have a great simulation center. So in that way, you should be able to do a lot of practicing on this issue. Talk to patients, get a quick history, right? Write a quick note. The best way to do this is do more and more cases. And if you can't do a lot of cases for one reason or another, there's courses you can take or see how they do it on the web. There's various ways, but you have to know how to do this. Because look at this. This is interesting. Look at some of the things that they will evaluate you on. Okay? So this makes sense, interacting with patients, getting a good history. Okay, we all know that. Getting a focused physical exam, focused, right? You can't do a full physical exam because you only have 15, 20 minutes per patient, right? So if you do a full neurologic exam, just a neurologic exam takes 20 minutes, right? So no, focused, right? A guy has shorter breath, you're going to examine the hearts and the lungs, kind of like that, okay? Look at this, counseling and giving information, organized progress note, differential diagnosis. Okay, this all makes very good sense, but look at here. Here's some of the reasons why people get negative points. So they take points taken away from them. Wash your hands. Look at this. Number one reason why points are taken off in the clinical skills exam. People go in the room and they forget to wash their hands, they take points off. Look at this. Good eye contact, right? So you ever see people writing notes and the patient is in back of them, especially if they're writing it on the electronic note, right? Yes, Mr. So-and-so, you're doing well. Okay, and they're writing. And the guy's in back of them. So, it's not a good interaction, right? They want you to talk to the patient. Ask permission to examine, have open-ended questions. Why did you come here? Let the patient speak. All this stuff is important, but most of us don't think about it. My point is that if you do a lot of this, and you see a lot of these patients, and you've practiced a lot on this, because the most important thing here is, look, here's what it comes down to: practicing and practicing and practicing and practicing. Then it comes as a second nature, right? You walk in, you wash your hands because you've done it 20 times before. You ask them, why you came here, because you've done it, 100 times before. Some of the interesting things they grade you on. Look at this. When they leave the room, tell the patient what to expect, right? So we had the student that was really a very smart student, in the top of his class academically, and when this person went through the clinical skills, she would leave the room, would tell the patient, I think you have this, and just walk out. And the patient says, okay, okay, what's going to happen next, doctor? Is the nurse going to come and get me? Are you going to give me a prescription? Are you going to send me to the hospital? So you have to leave that room with, okay, I think this is what you have, or you may have. We need to do some additional tests. I have to, get my nurse to come in and get blood from you, or I have to send you to the lab, or sometimes if it's a serious condition, send you to the emergency room. But my point is, you close the encounter, and if you don't do this many times, and you don't get a lot of experience, when you're a little stressed because now you're getting tested on this, you're going to miss some of these issues. So the most important thing is to practice. And let me give you a couple of last things on here. The clinical skills, guess what? How do you get graded? You get graded by one of the professors looking at your note and your history taking. Right, so they look at your note. Now, this is a good note. Right? This is a good differential diagnosis. They put a good plan together. And the second person that grades you on the clinical skills is the patient. The patient who's an actor, right? And they say, okay, yeah, now, he didn't ask me, the questions that they should have asked me. He didn't look me in the eyes. He was looking at other, was looking at his note all the time. He didn't introduce himself, right? Oh, yeah, and here's the killer. He didn't wash his hands before he came into the room. Okay, now you're done, right, with all these things. So my point is, you're going to get graded by the patient. And if you think about it in real life, don't you get graded by the patient, right? So they think that you're a good doctor, they come back and see you. If they think that you're not a good doctor or you don't give them good information, they go see somebody else, right? That's the concept. But the point is that this has become a very important part of the step 2 now. And it's easily doable and easily passable as long as we practice enough. We have to practice enough. There's no two ways about this, right? So now we did step 1, we did step 2, and we did the clinical skills. All right. So now you guys are ready to go off and decide to go to the United States. And I want to tell you from a program director, I used to be a program director before I was the chief of internal medicine and the chief of staff. And the program director sees this. They look at the scores, right, because they allows them to sort out the candidates, and we all agreed that we have to get as high as possible. It's not the end of the world, but you have to try to get as high as possible. Try, especially in step 2. Step 2 is important. They're going to know it's important to you because you're going to do clinical medicine. That's where you want to do the best. And if you get to step 1 and do it well there, that's even better. The second thing we said, and this is what the program director is going to look at, is do you have experience in the United States? And I think I explained why this is important. Because he or she knows that you know the system. He or she knows what you're up against. So it doesn't happen like after a month, you say, oh my God, this is horrible, and I think I want to go back and do residency back home. And, then you get up and leave. And they know that if you've been to the United States and you've rotated there, you have a good sense of what to expect. And why is this so important? Because they know how you're going to do based on the letters of recommendation they got from people that saw you in a rotation in the United States. It's a different environment there. But so this experience in the United States, if you can do it, and I understand the commitment, believe me, very, very important. 4 weeks, go and do whatever you decide to do. As I said before, if you're going to do surgery, it probably makes sense to do a surgery rotation there. If you're going to do medicine or pediatrics, it probably makes sense to do one of those there, right? You want to do the rotation that you're likely going to try to go into residency. And then letters of recommendation. All right, so here's the deal. You have to get letters of recommendation from your dean here, right? The dean writes a letter of recommendation, how you did overall in your 5 years in medical school here. You will get 1 or 2 good letters of recommendation, probably 2, from your professors here that you've done well. It would be great to get it if you decide to do surgery from your professor in surgery, or medicine from your professor in medicine. And please, they have to, I think your medical school is good at this. I've seen some of the letters of recommendations from here. They have to speak, to your, specific to your character, to how you did in the rotation. So some of the letters of recommendation that we see from international schools say, okay, Mr. So-and-so or Dr. So-and-so was wonderful. Well, that word doesn't matter. It doesn't mean anything to a program director. They want to see how you did, that you were good with the patients, that you got a great score in your, in your tests here, that you were on time and took care of a lot of patients and have a lot of experience in what you're going to do as a resident. That's what they want. They want these letters to speak specifically about your character and your skills. Very important, right? So not just this person is wonderful. They have to speak directly how you did. The dean's letter actually has to say how you did overall, how you rank as a student in the medical school. Are you in the top 20%, and so forth. Very important, right? So, and then if you did a rotation in the United States, letters of recommendation should be received from people in the United States. As I say this again, this is super important, very important. If you could get 2 letters of recommendation, from one attending and one senior resident, or 2 attendings, depending on how many weeks you do and how many people you interact with, that's wonderful. Please make sure you talk to the attendings and you tell them about the letter of recommendation, and they agree to write it, and you tell them in time. Because what you do is you have to apply through this portal. It's called ERAS, E-R-A-S. You have to apply through this portal, and they have to upload the letters through this portal. If you tell them last minute, they're not going to be able to write this letter of recommendation, a good letter of recommendation, on time and upload it. You want them to do that way before. You don't want to leave this to last minute. This portal, at some point, there's a deadline, which you can't upload letters after that. So if you tell them in the last couple of weeks, there's no way that that letter is going to be on there. If they're trying to upload letters in the last 24 hours, guess what? Everybody else is too. They're going to have a hard time doing this. So my point is, get this done before. Talk to the people, decide who the important people are that you're going to get the letters of recommendation from, and try to get this done months before that deadline. Okay? So that's the letters of recommendation, and the 2 most important things: the scores. We have to pass the USMLE or else we can't go, and the experience in the United States. Some other factors. If people go to competitive residencies, research is sometimes, especially in academic hospitals, we look at research. So if you've done research, I'm not saying you have to. Again, it's not a end of the world thing. But if you've done research, talk about it. If you've written a paper or have done some type of manuscript or worked on some basic science research, this is a plus. Again, this is a way to distinguish yourself from some of the other medical students that everybody kind of falls in the same level. Right? So research becomes important. If you're going to tell somebody, look, I'm going to be a researcher, I'm going to do academic medicine and do research in, I don't know, some type of cancer. Well, listen, they're going to say, like, well, have you done research? Right? So if if you're going to say something like that, you probably should have some experience. Okay? The cover letter. So when you apply, you have to write a cover letter. The cover letter is, you write about yourself, right? You write about your experiences, why you chose to go into the field of medicine and the field that you chose, whether it's surgery, pediatrics, or medicine, or OBGYN, or whatever, or some subspecialty. You should speak about yourself in that letter. Kind of speaking about yourself is difficult sometimes, but you have to give a sense to the director of why you've made the choices you've made, and a little bit about the future. And program directors understand that things change. So you may decide to go into medicine to become a cardiologist, and then you don't like cardiology, and then you decide to go and do hematology, oncology. So they understand things change, but it's nice when you see somebody has thought out things and has a plan going into the future. Here's an area where people speak about, their hobbies sometimes, and their, other things they do out of medicine. it's nice to see that people do other things outside of medicine. It's important to the program director to see a more well-rounded individual. If you write something, please, please make sure it's true and you could defend it, right? If you write something that you are a marathon runner, you better know, your last marathon, the time you did it, right? Because they're going to ask you something about that. Or maybe they won't ask you, but it may come in a conversation. As I was telling the staff the other day, I've come into conversations not knowing it. I asked somebody, well, I'm glad you like this, and it was obvious to me that it was not true. That's not what you want to do. Because let me tell you, when you're at an interview, that means they're actually thinking about recruiting you. So you've made the first cut. If somebody's interviewing you in the United States, they're really thinking about recruiting you as a resident. Well, if that cover letter says anything that questions your character, like saying stuff that is probably not true, they're not going to be thinking about you anymore. So you want to tell them the total truth. And that probably makes more sense because, look, you want them to know what they're getting, and you want to know what you're getting from them. So it's okay to ask them a lot of questions also. But my point is, look, you want to tell them who you really are, not who you think they want to, have in front of them. And if you don't make that program, it's okay. You're going to find another program. That's the good thing about the United States. There's a lot of alternative solutions, right? And then on the interview, it's very important. So you're in that interview, they're thinking about you, you made the first cut. If you do well in the interview, right, you got a pretty good chance of making this program. The more interviews you get, right, so it's a kind of, chances, right, the more likely you're going to, be in a residency in the United States. I would suggest in the interview, be yourself, be on time, tell them the truth, tell them what you want to do. Don't tell them don't tell them what you think they want to hear. If they want somebody else, then you don't want to be part of their program. And it has happened to all of us. You kind of wanted to go somewhere, but if they don't want you, well, you don't want them either. There's going to be another place where they like you for who you are, and you're going to be a good match there. Right? So those two are very important, the cover letter and the interview. Right? Okay. And then a couple last things on the residency. Last things on the residency. So I think I've already taken a lot of your time. But here it is. Some of you will decide to do a very competitive residency. So these residencies here, radiology, dermatology, orthopedic surgery, anesthesiology, and some other ones, maybe ophthalmology, are very, very competitive. So in other parts of the world, these residencies are not very competitive. So when you go to Europe, dermatology, everybody wants to be in internal medicine, or they want to be in surgery, or they want to be in pediatrics, really strong, difficult residencies. Well, that's not what happens there. So for whatever reasons, and I could explain to you, but a lot of people like quality of life. They've incurred a lot of loan in medical schools, right? So they want to go into easy residency. So these become difficult to get into. Actually, orthopedic surgery is not an easy residency. It's a very difficult residency. But for one reason or another, these are difficult residencies. So in these residencies, look, if you're going to apply, you better have everything lined up. A good USMLE score, right? You better have experience in the United States. You probably need a little bit of research, otherwise you're not going to be different. And most importantly, please, and this is happened to a lot of foreign grads. If you're going to try to get into one of these residencies, which is totally fine, please have a backup in case things don't work out. So, for example, last year, out of the entire United States, out of all the dermatology slots, there was only 3 international graduates that got slots for dermatology in the entire United States. The year before last year, in 2016, one. Okay, so look, you may be that one person, you may be one of those three people, but look, I'm a person that deals with chances. I do a lot of numbers research, and I'm telling you, you better have a backup, right? So you better think like, okay, maybe I want to do dermatology, but what if I don't do dermatology? Okay, I'll do internal medicine for a year and maybe reapply for dermatology after that, right? So you have to have a backup. Backup is very important. Backup also is important that, look, don't interview in the same hospital for both residencies unless you tell everybody. So one time I had this resident tell me, my whole entire life I wanted to come and do residency in your program. Okay, I believed her. And then, a program director from another program from our hospital told me that she interviewed there, and one of these specialties, and she said the same thing to her. So, okay, who is she lying to now? You don't want to be that person where people have questions about you. So it's either you tell the truth and you tell the program director, listen, I applied for dermatology here, but I just want to let you know I've also applied for internal medicine because this is a difficult program to get into. Or you apply to another hospital and you don't have to share this with them. But if you do, be careful because, it's a small world and people talk about candidates. That's my point, right? But the important thing here is to protect yourself and have a backup, okay? And then step 3, I think that's the last thing I want to talk about testing. Step 3 is a management, clinical management focus. It's a test about clinical management. The American graduates take it when they're in the second year of residency. Some people will take it in their first year, but first year of residency is so tough and complicated, and people work extended hours, and so you probably want to leave it for the second or maybe even the third year. People ask me, can they take it before residency? You can, but with all these things you have to do, why do you want to do that? So I would suggest, my suggestion is, listen, leave that for later. Don't worry about it now, right? So leave it for later. Your goal, if you're going to try to be in America, is to focus on step 1 and step 2 and practice as much as you can on patients for the clinical skills. And last thing I want to, because some of the students, the senior students asked me this yesterday. You want to do as much as possible as a current student. You want to take step 1 as close as you can to when you finish the basic sciences. I cannot emphasize that enough. I know it's going to put a lot of strain on you, but look, once you finish year 2 or 3 or whenever you guys finish the basic sciences, that's when you know the most. I'm not saying you can't take it 5 years later and pass it. I know you could because I did that and everybody else did that, but you want to take it as close to the time when you finish the basic sciences. Same thing when you do the clinical work. You want to take it as close as possible to when you finish your clinical work here at the university. Whether that's right after year 5 or close to year 5 or just before, it doesn't matter, but that's the best time because you know more at that time than any other time. If you decide to wait a year and study, after the 5th year, that's okay. But listen, you have to be studying for this exam, right? You can't just, do something different and then all of a sudden starting from you. That's more complicated. It takes more time and it takes much more of a learning process. So my recommendation is to try to pass these tests as close as possible. Okay, let's say you don't do that. because, medical school is stressful. All right, the other possibility is you graduate and then you decide to take both of these tests. And you don't have to take step 1 first and then step 2. You could take step 2 first, right? Because you just finished the 5th year. Take step 2 and then sit down and study 6 months, whatever, for step 1. So you could do that, but it's much easier if you do it earlier. Okay, now look, if you graduate from medical school, you cannot do easily these rotations that we talked about in the United States. See, as a student, you could do it, but once you graduate, now you're in a different category. You're a doctor, and these rotations are much harder to do as an international doctor. You're not a student anymore. You say, well, I'm a student, I'm still learning. No, for them, you finished medical school. So there's different issues with liability insurance and stuff like that. It gets very complicated. So especially for the rotations, please, if you're going to do this, you got to do it while you're a student, before you finish medical school. The tests, you could do it later. It would be preferable to do while you're a student, but you could do later. But the rotations you have to do. Okay? And please, try to study as much as you can. And, because remember, the goal is to get as high as possible, right? Okay. I'm going to stop there, and I'm going to take your questions. Don't be shy. Yes. Sorry, I'm sorry if this far I won't hear, but I'll come a little closer. Please, yeah, sorry about that.
Your step 1 results are only relevant for the next 7 years after you finish taking the exam.
So you mean step 1 and you finish and go to step 2? Is that what you're saying?
Yes.
Yeah, so
My question is, because you do step 3 during residency, does your step 1 result have to still be available when you are taking your step 3 exam?
so your step 1 available for step 3, you mean?
Yeah.
Oh yeah, your step 1 is good after you pass it. You don't have to worry about that.
No, but there's a time period, right? There's a time period of 7 years in which
It's a time period of 7 years. But look, think about this. You should be taking your step 1 probably like in year 3. That's the earliest you're going to take it. And then a couple of years after, you take your step 2, and then you get into residency. Oh, you have time. There's not, I don't think that that's going to be an issue.
there's no rush.
No. No.
Okay, but sorry, just to clarify, so is it yes or no, like, do you still require your step 1 result to be like viable when you take your step 3 exam?
No, they have to be, it's for residency that you have to have 7 years from step 1.
So after residency,
Yeah, you could take step 3 later. They don't care. It's for residency that somebody's going to say, well, you have taken this more than 7 years. I'm not sure about you. Yeah. Mm-hmm. Other questions? I'm sorry, you have to talk a little louder. Sorry.
We're from clinical school from term 1. We could not join you yesterday, and that's our your fifth day.
Okay.
So I just wanted to ask, let's say we fail a paper, we don't need a certain score to fail. Like you said, a high score would be 250, but let's say we get a 240 and we want to restate the paper.
You can't take it again. So that's, no, forever. You cannot take it. So listen, unless you wait 10, 15 years, you cannot take it. So the only way that you could take this exam again is if you fail, not get a good score. And say once you pass, you are done. And please don't, if you don't get a good score, you don't get a good score. It's fine. You take step 2 and then you try to get a good score. And if you don't get a good score in step 1 and 2, okay, then you try to improve yourself in other ways, through research, through doing a rotation in the United States. So there's other ways. It's not the, it's not the kiss of death, but you should try to do as best as you can. But you cannot take that because about 30, 40 years ago, they used to do that. And people used to take the exam over and over and over again. Well, you take the exam over and over again, you know a lot of these questions that they give on the exam. So you cannot do that. So you pass it, it's done. You move on. Okay? Yes. In New York? New York is the easiest place in the world to get into. Because they have the most, I knew it. You want to be in New York, right? So they have, right now, the largest percent of international students in residencies there. They have very large hospital network. Many of those have international graduates. Many of those take people for rotations. So you could go to some of these hospitals, do a rotation, and then apply to these hospitals, right? So New York is wide open. Some other states are not as friendly. Boston is not as friendly. Philadelphia is not as friendly. Other places that are friendly are Chicago, New York, Florida is very friendly, Texas is very friendly. But there's so many programs in the United States, there's always somewhere you could find a good program. And what I would suggest is, if you are, if you want to do, especially if you want to do academic work and not only, go into private practice, there are places like university hospitals, like in Alabama or Kentucky, that you could go and do internal medicine or general surgery. And not everybody wants to go to Kentucky, but the University of Kentucky is a top hospital. So you could get great training. So you're there for, 3 to 4 years, right? That's minimum. 3 to 4 years is minimum residency in the United States. And then, well, you did very well in internal medicine there or some other specialty, and then you could go and subspecialize somewhere else. For example, in New York and Chicago, again, at a large academic unit. When you go to the big cities like New York and Chicago, even though there's a lot of programs that take foreign graduates, international graduates, well, be careful because a lot of the Americans want to go to New York also, and Chicago and Boston. So some of the top programs there are going to be, the positions are going to be consumed by Americans. But there's secondary hospitals that you could go to. So you either say, okay, I'm going to go to secondary hospital because I want to go to New York, or I'm going to go to a top university hospital, but I'm going to stay, 4 years in Alabama. Something like that. I'm sorry? The secondary hospitals are the non-direct academic affiliates. So for example, the Cornell Hospital, right? Cornell University, or the medical school at Cornell, is associated with New York Hospital. That's their primary hospital. Mount Sinai School of Medicine is associated with Mount Sinai Hospital in New York. Those are their primary sites. They're the primary teaching sites. They both have secondary hospitals. There's one in Long Island that's associated with Cornell. There's one in Staten Island and Brooklyn. So these are still very good hospitals. It's just you're not going to be in the main hospital. That's what I'm saying. Right? Mm-hmm. Yes. Hi. Oh, my pleasure, my pleasure. I hope so. I hope so. The which students, I'm sorry? Malaysian students. I don't know about Malaysian students, but listen, I do know about other international graduates, and you all you come from a good medical school that's well respected. You know English, and your curriculum is in English, which is a major issue, so that you speak English well and you communicate well. And there's no reason why, you know, there should be any issues. And listen, I know there's, all these thoughts about getting visas to the United States with the current situation, but right now, Southeast Asia and Asia, the visas have going up, so I, I don't see any problem. Anybody here, and the students I talked to yesterday, I mean that they should have any problem coming to the United States. Listen, provided you do 2, 3 things. So again, it takes a commitment. And some people say, listen, do I need to do all these things? Why do I need to do all this stuff? I could stay in Malaysia, or I could go, to Europe. I could go to the UK. You can do that. That's not an issue. But there's, training in the United States is special. You see a lot of patients. You're in the forefront of some of the latest, advances. So, and especially if you will do an academic career or be involved in serious research, there's no place, that is better. I mean, there's other places that are just as good, but there's no place that's better. So it's a commitment, but it's something that, I did. And, sometimes you wonder, should I have done this? But yeah, at the end, you say, listen, I did get a lot of things out of it. Mm-hmm. Yeah, so I don't see any problem people coming from here. I don't, I think you have a lot of positive things that would make you, a very good candidate to go to the United States. Mm-hmm. Yes. So you have to ask around. So that's the truth. So the question is, how do I know which hospitals are good and which are not good? So you have to ask around questions. Generally speaking, what I talked about, the level 1 hospitals that are linked to universities, those are top hospitals because their training programs are very good. They've been there for a long while. They've trained a lot of residents. The people there are very, into academics. They're usually large research programs. Some of the programs in the United States, have hundreds of millions of dollars in research money coming from various projects. So for example, when I was interviewing, I didn't know about University of Virginia. But University of Virginia Hospital is linked to the University of Virginia. It's a major medical center. It's a wonderful medical center. George Washington, Georgetown, University of Chicago, all these you can't lose. So you start from there. Okay, the second thing is you look at so these are statistics that you could look up on the web and in various books. You see how they match. So if it's a good program, it matches all their positions every year. If it's not a good program, they have unfilled positions. And you have to ask yourself, why is that? Why do they have unmatched positions? So it may be a geography issue. So for example, the University of North Dakota is actually a pretty good place. But I'm not sure everybody wants to be in North Dakota. So it could be a geographic issues, but it could be in other issues too. It could be because the hospital's having a lot of, training issues, or they don't have the right staff. So that's another thing you have to look at. And then the third is word of mouth. You talk to people when you interview in these places. right? You talk to people and you talk about, hey, did you have somebody that's, finishing this year? Let me talk to them about the program. The residents are very upfront. The residents are very, they're very collegial. They're going to come up to you and say, oh, no, this is very problematic. They work us to death, like you don't want to be here. And so, they talk to you. So those are the three ways of getting, the program that it's going to be good for you. But listen, so here's another thing. The fourth component of that is where they're going to give you interviews. So where you think you're going to go doesn't always mean you're going to get interviews. Some of the programs that I mentioned, they take one international graduate a year. So University of Chicago took one graduate, and I knew this guy. This guy was amazing, right, in their internal medicine program last year. Right, so there's two components. You have to find good hospitals that are good, and then you have to make sure, you are, they ask you to interview in those areas, right? But that's the bottom line. Mm-hmm.
One final question. Thank you again for your talk. Has given some really important insights into the US residency pathway. I think IMU's students are in a more unique situation, as in IMU has a lot of partner medical schools and we have a lot of different pathways to choose from. Your presentation was mainly focused on the US residency pathway. Would it be possible for you to compare between the US residency pathway to, say, the UK specialization program for doctors in a few key factors? For example, the number of years for someone to become a consultant, the competition rate, for example, the applicant to residency slots ratio, and lastly, the remuneration for doctors.
Yeah, I don't know about the UK. Even though I trained 20 years ago before I came to the United States, I don't know, and I don't want to give you misinformation. One of the biggest differences there, obviously, there's access from the European community, although now, who knows what's going to happen with the UK. But one of the important differences was that you could go straight to subspecialty there. Right, you don't have to do 4 years of medicine and then do 3 years of hematology, oncology. But I can't tell you those numbers. I would be giving you the wrong information. What I can tell you is that UK and Canada, I'm familiar with graduates of those two systems. They are excellent. So if you say, listen, I decide to go to the UK for one reason or another, that will be just as good as saying I'm going to go to the United States. It's a matter of what's better for you and the environment. I think that in the European countries, and I think Canada is more like the United States. Their system is like, when I look at their candidates, their first and second year candidates, very similar. The European, including the UK, is a more graded responsibility in residency. So, for example, there is no one there that expects, for you to start on the 1st of July. That's when residencies start in the United States. And to walk in and, okay, here's your 12 patients, doctor. I'll see you 2 hours later after you've seen everybody to discuss them. That's not going to happen in Europe. There's much graded responsibility. But in the United States, once you're an intern, you're a student, you have responsibility right away. They believe that the only way that you learn fast is, they throw you into the water and you start swimming. And I'm not sure that's right. So I'm being upfront with you with that, because I saw, a lot of people get stressed and stuff like that. And if you go now to the United States, the work is about 80 hours a week. So I said this to somebody, a foreign graduate about a couple of weeks ago, and she goes to me, doctor, the working week is 40 hours. Yes, but that's not what residents work, because they're on call overnight, so your week is around 80 hours, and it's an intense program. They feel that the intensity, you see a lot of patients, you learn really fast that way. It's not, I'm not saying it's right, but I'm saying that's the thought process. I don't think that's the way it is in Europe. No, I know that's not the way it is in Europe. That's why in many places in Europe, internal medicine is 6 years. Because in 6 years, you see about the same patients, maybe, as 4 years in the United States. In fact, it's not 4 years, it's 3 years in the United States. It's 1 year if you do a chief residency. So it's very intense there, very intense. You see a lot of patients. When I hate to say this, this is, so now a little bit over 20 years, I was a resident. There were no time limits. So now, there's laws and regulations in how long you can hold a resident to duty. They cannot have you there more than 80 hours. When I was a resident, there was no rules and regulations, and the thought was you lived in the hospital. I'm being serious. So you were there for like 120 hours a week. Well, do the math. There's only 24 hours in a day, 7 days a week. So most of your time you were in the hospital. That's why they were called residents. They're still called residents, but the term came from you resided in the hospital. You will take all the patients that would come in. There were different times, but the learning experience was amazing because you saw, all these patients. So I can't speak to the differences, but I could tell you these are differences. Mm-hmm. Yes.
J1 and H1B visa.
Yes.
As far as I know, correct me if I'm wrong, J1 visa, we have to return to our own country for 2 years after the residency, right?
You don't have to. So let me tell you. So a J visa means, yes, if you finish residency, you will have to leave unless, there's exceptions, there's always exceptions, unless you do 2 years in an underserved area. And underserved areas are sometimes university hospitals like the Veterans Affairs Medical Center that I work with. And so we had an interventional radiologist from Columbia that was outstanding, and we wanted to hold on to, so we sponsored his J visa. But you gotta work in this hospital then for 2 years, or you can go to a rural area where they sponsor J visas, and if you work in that rural area for 2 years, right now you're eligible for a green card, and you could do whatever you want. Right, so there's always pathways. An H visa is even better. If you could get an H visa sponsored, that's better because they could use these things called, high-level scientists, and they could actually give you, they could prolong that visa. You don't have to leave. A lot of the universities, though, are unfamiliar with H visas. The hospitals and universities, they're more familiar with the J visa. So if you want an H visa, you're going to have to do your own work a little bit and talk to a lawyer and see how you could get that. But that's also a possibility. Mm-hmm. Mm-hmm.
Yeah, about the clinical rotation. When do we actually do that?
When do you do the clinical rotation?
I mean, after we graduate from medical school or during the clinical days?
No. You can't do the clinical rotation. It's preferable you do it during medical school. Yeah, because remember what I said? Once you finish medical school, you're not a student anymore. And these rotations that your school will find and that we've used for foreign students, you don't fulfill that criteria anymore. See, once you finish medical school, you're not a student anymore, you're a doctor. And those rotations are typically for students. And because they're covered through different rules and regulations that apply to students and not to people that finish medical school. So I would suggest you do it through medical school. There's ways to do it. You do it, your third, your fourth. No, you shouldn't do it third year. Probably your fourth or fifth year, somewhere in between there. Okay.
What is the procedure to apply for the rotation? So what is the procedure to apply for the rotation?
So the procedure is, your medical school knows 5 hospitals that do this, right? And you say, I want to do it in August, of next year. And they say, okay, we don't have a slot in August. Can you do it in July? Oh, okay. So I could manipulate my schedule and do it in July. You go for 4 weeks, and that's it. They arrange that through the medical school. That's right, through your medical school. It should be arranged through your medical school. All right, I'm going to stop there, and thank you for your attention.